So thank you very much. Today I'll be talking about optimizing diagnostics for post-COVID vaccination surveillance. I have no disclosures. So stopping the COVID-19 pandemic really rests on three fundamental pillars. The first is to reduce opportunities for transmission and lower the burden of exposure when a transmission event occurs. And we achieve this through non-pharmacologic interventions such as masks, social distancing, and hand hygiene. The second pillar is to rapidly identify and separate cases from susceptible hosts, which is done through accurate, inexpensive, non-invasive, rapid, widespread, and frequent testing, which is a goal we've been trying to achieve since the very beginning of the pandemic. The third pillar is to safely and ethically reduce the number of susceptible hosts, which can be achieved through a widespread vaccination campaign, which is of course ongoing right now. And so while all three are necessary to stop the pandemic, I'm going to be focusing on the latter two here and the interactions between them over the next 20 minutes or so. So the roles for diagnostics, in a word, are ever evolving, or two words. In the pre-vaccination era, diagnostics really served two purposes. The first was to screen people for asymptomatic infection and therefore block transmission before it can happen. And secondly, for active case detection to help halt outbreaks, as well as to identify patients for clinical management. And the types of questions that diagnostics in the pre-vaccination era were concerned with included whether this person is infected with SARS-CoV-2. If they are infected, is this person contagious with SARS-CoV-2, or are they in the recovery period and not contagious? Or is this person reinfected after a previous infection, or do they have signs and symptoms of a persistent infection over time? In the post-vaccination era, you still have all the questions associated with the pre-vaccination era, but some additional questions that add some new complexities to it. And these include whether this person mounted an immune response to vaccination. Can I distinguish immunity due to natural infection from that due to the vaccine? And the question I think that's most important is this person protected from infection? And then lastly, similar to the pre-vaccination era, is this person who is infected, are they infected despite being vaccinated? And so the goal here in the post-vaccination era is to really develop high throughput clinical diagnostics that quantitatively measure correlates of protection and can distinguish natural infection from the vaccine response. And we have a paradigm for this in hepatitis B, where on the right, I'm showing the classic hepatitis B serology graphs, where you can see we can measure levels of antigen and various antibodies to different components of the virus, and use those levels to identify whether a patient is in early infection, chronic infection, or is in a vaccine-induced immune protective state. And so for a SARS-CoV-2 diagnostic, to identify these correlates of protection, we must identify and utilize a target that either directly blocks virus activity itself or plays a major role in disease pathogenesis, or that target directly correlates with another molecule that blocks pathogenesis. And in addition to that, this target must help differentiate prior infection from vaccination. So how to identify what that potential target is? And so there's a lot of work that's been done on the role of natural infection and the subsequent immune response, and we can turn to that to try to get some targets to begin with. And so we know now that natural infection raises a very broad humoral and adaptive immune response. And the components of that response include antibodies, memory B cells, CD4 helper T cells, CD8 cytotoxic T cells, as well as memory T cells. And so I will focus first on the antibody response and then spend some time at the end of this talk talking about the T cell response. So we know that antibodies developed during natural infection target the nucleocapsid protein and the receptor binding domain of the spike protein. And on the left here, I'm just showing some data that was published last month, showing the formation of IgG to the receptor binding domain in the top panel or to the nucleocapsid on the bottom panel by week from the onset of infection in a set of human volunteers and human study subjects. And you can see that The response to the RBD arises a little earlier than to the nucleocapsid protein, but then both of them level off over the next 2 to 3 weeks. And we know that vaccines induce a robust response against the spike protein and RBD. So now instead of natural infection, we're targeting just a single component of the virus through the vaccine. And data from human and animal studies suggests that anti-spike receptor binding domain IgG blocks viral entry and is a correlate of protection. So on the left, I'm showing some physical data, biophysical data of the neutralizing antibodies shown in pink here, binding the receptor binding domain at almost exact same site and same conformation where the receptor binding domain binds the human ACE2 receptor on the cell. And this is a study that was published in the Journal of Clinical Microbiology that looked at a group of 120 people who boarded a ship in which an outbreak occurred. And they had pre-boarding serologies to compare to post-outbreak serologies. And you can see that those who had pre-existing neutralizing antibodies to the receptor binding domain were less likely to be infected than those who did not have those pre-existing antibodies. And so while this study is small, it would suggest that having those pre-existing antibodies to the spike protein or the receptor binding domain of the spike protein does confer a level of protection, which is consistent with the animal data, in vitro data, and now we know, of course, the phase 3 vaccine trial, which has shown that vaccine-induced antibodies are effective at preventing infection. So then the question is, why can we not simply measure anti-spike RBD levels to assess protection? And there are a number of reasons for why it's a little bit more challenging than that. And I like to call it as a number is just a number. Without the proper clinical context, it's rather meaningless. And so one of the things that's a big problem is that a wide range of titers and values may be elicited by natural infection or the vaccine. And therefore, just the presence of antibodies alone is insufficient to know whether they are protective or not. And from that same study of 120 people on a ship, I'm showing you some additional data here on the right. The light blue lines indicate the antibody levels among those people who are infected on board at day 0. And you can see most of them are below the limit of detection of the assay. And at day 30, post-outbreak. And what you can see here is that the range of responses ranged from absolutely no change in antibody levels, despite being infected, to very robust responses, and the vast majority of people lying on a continuous spectrum in between. And therefore, it's hard to say what level of antibody engendered by infection would actually be protective if people developed this dynamic range of responses. So that's one reason. The other reason is that the clinical diagnostics that exist right now for detecting anti-spike antibodies use very different methods for identifying them, as well as very different reporting results and different scales for that. And so it's hard to know what a number on one particular assay means when compared to a different assay. And so the two most common assays being used right now for measuring these antibodies are ELISA assays and the chemiluminescent assays, CLIA assays, that are high throughput and used by platforms such as the Roche platform, Diasorin, and Abbott. And so what is really necessary here is to identify a standardized threshold of antibody levels above which an acceptable degree of protection is conferred. And so what I'm showing you on the right is just that, except that it's not in humans. This is animal data from macaques. And so this is a study published late in 2020 showing that animals that were not protected, who are shown here in gray, versus those who were protected, had lower levels of pseudovirus neutralization antibody titers, which I'll talk about in the next slide, as well as lower levels of an actual ELISA titer against the receptor binding domain. And they were able to cleanly differentiate these two groups, or almost cleanly differentiate them, with the threshold value of 53 for the neutralization antibody titer and 100 for this particular ELISA assay. And so this is the kind of data we need to then inform epidemiologic studies such that when we follow people over time and quantitatively measure their antibody levels, we can say people above a certain threshold went on to not develop infection, whereas those who had antibodies below this level were at higher risk for infection. So it's a combination of both in vitro work as well as epidemiologic studies. So just a word on plaque reduction neutralization, because it's a very critical assay that we use to correlate what we see in our clinical diagnostics to actual function. And so it's one of the few assays we use that actually quantifies levels of functional antibody, and it's considered a gold standard diagnostic. The downside of plaque reduction is that it's very labor intensive. It takes a long time to perform these experiments, and it's quite costly. There's an additional aspect in that if we were to use live SARS-CoV-2 virus, there requires a higher level of biosafety when handling such an infectious particle such as that. And so what many labs do is in fact use not SARS-CoV-2 itself, but a pseudovirus that is expressing a recombinant spike protein, and therefore it reduces the amount of safety needed to operate with it. However, it doesn't introduce possible artifact due to the fact that this is not actually naturally occurring virus. And so on the right here, I have a schematic of how this neutralization assays work. So in general, we take serum from a human, heat and activate it, and add it to either live virus or a pseudovirus that expresses the spike protein. And then we add it to a 96-well plate, where each well is coated with human cells in a monolayer at the bottom. And we incubate those together over time. And then after a certain incubation period, we measure something called a cytopathic effect, where if a virus infects a cell, we expect to see changes to that cell, suggesting it's been infected. And so if a sample from a human has antibodies that block the ability of the virus to infect a cell, we expect that there should be a reduction in the formation of these plaques relative to a sample with no antibody present. And so the titer of the human serum that reduces the plaque formation by 50% is the plaque reduction neutralization titer 50, is the marker we use to compare or assess the presence of human antibodies in the serum. And so correlating results from an ELISA or a chemiluminescent assay to plaque reduction titers is really critical to understand what these numbers from these clinical diagnostics actually mean. But we do know that they can vary significantly depending on what the platform was used to develop the antibody, to report the antibody levels, the isotype of the antibody itself, whether it's IgG, IgM, or IgA, and the time since the infection occurred in the host. And so I'm showing here some data from Dr. Koopman's group that compared titers or values obtained from clinical diagnostics that measure levels of anti-receptor binding domain antibodies to plaque reduction neutralization titers. And so you can see here that correlations range from up to 0.83 for this particular IgG ELISA to down to 0.75 for the diazorin liaison XL chemiluminescent assay. And so this variation adds another level of complexity to the interpretation of these numbers. And it basically means that for any assay a hospital or a lab plans to use, they have to do their own plaque reduction titers to compare and interpret the results put out by the instrument. And furthermore, to be able to compare across instruments, we need to run samples from each of them with the same neutralization assay to quantify the variability across platform. And then, of course, what to do about the variance. So the measurement of these anti-S-RBD levels or titers may not actually reflect the functional activity of the antibodies against these newer variants of concern. And so to overcome this, we require regular surveillance with convalescent plasma and post-vaccination samples at day 0, day 14, and day 42 post-vaccination to assess the neutralization activity using either live SARS-CoV-2 or pseudovirus that contains the variant spike proteins. And as I said in the previous slide, this exercise must be repeated for every clinical diagnostic because every clinical diagnostic will give you a different range of values depending on how the assay is run. Above all, this requires very close coordination between governmental agencies that are involved with public health, diagnostics companies, and hospital or academic labs to work closely together to maintain very close surveillance and stay on top of these emerging variants as they spread throughout the various regions of the world. So I'm going to switch now from humoral or antibody-based immunity to adaptive immunity. And so, as I said before, natural infection and to a lesser extent, vaccination raises a broad humoral and adaptive immune response. But we do know that antibody responses are not detectable in all patients, and particularly those with mild infection. Yet the vast majority of these people do just fine. And antibody and virus-specific B cells may wane, but we do know that memory T cells may be long-lasting and result in a memory response much later down the line, even if you cannot measure circulating antibodies. And this has been shown in particular with SARS-CoV-1. And lastly, CD4 and CD8 T cells may contribute to the immune response independent of the B cell response, which we know from decades of immunology work. On the left here, I'm simply showing the waning of neutralization titers in asymptomatic and symptomatic people over time. And so interestingly, the CD4, based on studies that have been done doing mega pools of peptides, SARS-CoV-2 peptides, we know that the CD4 T cell response in natural infection is raised not only to the spike protein, the nucleocapsid protein, but to many other virus proteins, including the membrane protein, as well as a number of non-structural proteins. And interestingly, spike-specific CD4 cells tend to show a T follicular helper cell phenotype, suggesting that they're really responsible for optimizing the antibody response to the virus, indicating how important that is. But that CD4 cells targeting the membrane or the nucleocapsid proteins tend to have more likely a Th1 or Th17 phenotype. And so the humoral and the adaptive immune responses are very tightly linked to one another, and infection itself leads to a very heterogeneous response. Each compartment, which I'm showing here on the left-hand side here as being either an antibody response, memory B cells, CD4 or CD8 virus-specific cells, or IgA, each of these compartments has unique kinetics. In this particular study that came out a couple of weeks ago, this group showed that 64% of people developed antibodies or responses in all 5 compartments at the first month post-infection. But that number dropped to around 43% at 6 to 8 months post-infection. However, 95% of people still develop responses in 3 out of 5 compartments at 6 to 8 months. So it does seem that the immune response is durable over time. However, when they tried to correlate anti-spike RBD IgG titers from ELISA to the presence of memory B cells or CD4 memory T cells, the correlation was very, very poor. And so if we were trying to understand the T cell or B cell memory response, it is not possible really to do that using our clinical diagnostics for antibodies. And so the bigger challenge with assessing the T cell response, which may be very important for SARS-CoV-2, is that the vast majority of assays are currently still in research use only. And while we know a fair amount about the breadth and duration of T cells to natural infection, the same level of characterization is yet to be really reported for vaccine-induced T cell responses. Interestingly, in many of these studies, they took volunteer samples from healthy people pre-pandemic and showed that circulating T cells stimulated by these epitope megapools resulted in SARS-CoV-2 specific responses in up to 60% of healthy people, suggesting that prior infection with endemic coronaviruses can actually lead to cross-protection to SARS-CoV-2. Ultimately, if T cells are going to be assessed for COVID-19 diagnostics, there are a couple of models that we've used for other infections, such as interferon gamma release assays, which have been used for many years for assessing mycobacterium tuberculosis infection. One example would be an ELISpot, for instance, and flow cytometry measures, which can try to identify both CD4 and CD8 T cells, depending on both effector or memory responses. But there's quite a bit of work still left to be done to bring T cell diagnostics to clinical use. So I want to thank you very much, and I want to give a special thanks to Dr. June Liu and Dr. Fabian Lucas and Dr. Manfred Brigel for thoughtful discussion around this topic.